Hello everybody. Today we're going to look at one of those variations of normals, kind of those freak of natures that are sometimes are kind of freaky, but they don't have to be freaky. And in the efforts of it being October and Halloween season, I've seen stranger things than this, no pun intended, but today's an interesting case. It's a lower bicuspid turned molar. I mean, that's essentially what it is. And from that, we can ask ourselves a lot of questions, but let's take a look at what this is. It's going to be a retreatment, which are always kind of challenging. It's number 29. And go ahead and look at that. I mean, the previous doctor clearly, when he accessed, probably was just thinking it was maybe a single canal tooth. Maybe he or she couldn't find the other canals. I don't know. It's interesting when you look at that because it does look like a single cone. And perhaps that's sealer getting into isthmuses or nooks and crannies. So let's take a look at the cone beam, and man, that is a C-shaped bicuspid. We know of C-shaped canals, and they exist in the bicuspid route. Obviously, it's right here. But clearly, let me move this over a little bit. Clearly, you can see that it's fused to the buccal. And it's C-shaped fused to the buccal. And it does look like a single canal with sealer going into kind of the mesial lingual side of things and a single cone when you look at that. It's also got a kind of a funky looking apical periodontitis. The lesion radiographic rarefaction that's on there has got some interesting shapes if you look in the cone beam in the lower right. So let's run through these little cross sections here and kind of identify it. So when I look at that, I know I got a distal lingual connected to the buccal, and I know I got a mesial lingual probably connected to the buccal. So I'm going to use that nomenclature. I'm going to call it an ML, a B, and a DL by virtue of what I'm looking at. And let's just kind of appreciate this variation of normal. There's the double buccal legs. So, what's it going to look like inside? So here we go. Let's take a look at this thing. Right. All right. Let's get my mirror in here. And there's some composite kind of covering some gutta percha. And it was roughly, the filling fell out. And we have decay present. This is just a slow speed. And you can see how much is kind of coming out as I kind of work around. And you know what? So my mind is kind of thinking, I understand that image, and so I'm already trying to find what my mind created, and that's the value of the CBCT, right? That three-dimensional information is going to teach me where to look and how to access. And now I got a stain track from H to breakfast here, but how and where are these? And it does look like it's been kind of hogged out in an effort looking for that anatomy, but it's strange. Like I said, it's a strange case. I'm going right now for the distal lingual, quite frankly, because it was the most prominent and visual on the x-ray and the CBCT. And so I'm kind of going through that, and I'm not really putting pressure. I'm just feathering it. I'm letting the burr do its work and just remove the soft part of the dentin and hopes to find some visual clues to where that horseshoe, that buccal horseshoe, that C-shaped appearance really is. And as I look and I start letting that cloud form, and what I mean by cloud, when you just use a slow speed, kind of the debris packs, if something's open, it just kind of packs in there. And if I look right there, it appears that I found that distal lingual right here. And all I did is that burr kind of packed some debris in there. And sure enough, I think I've just discovered the DL. So, and now I'm curious if I can pick into the ML. And I'm kind of just feeling with an explorer to see, can I appreciate isthmus formation between the two? And I'm a little bit nervous because it was a furcated bicuspid, and I don't want to go too deep. I don't want to go in the wrong direction and perforate it somewhere. So I'm just kind of getting a feel for things, and kind of felt like the gutta percha is a little bit in my way, a little bit. So you know, that was kind of frustrating. But when I go right to my Rotary Explorer, it drops right in, and man, you just get that sigh of relief, like I've hit the jackpot right there. And that's good, because that could have been difficult, and it wasn't difficult. I mean, 6 minutes into this thing, and I've already found the DL. So next question is the ML. So I'm playing around with it a little bit and trying to appreciate that. And now I'm trying to pick at that ML, and it didn't like fall into place quite like I thought it would. And so I kind of gave up for the time being on it, and I'm now trying to pick to see if I can pick into an isthmus leading me over into that gutta percha and maybe try to outline that horseshoe, that C-shaped canal. So after that, I just went to town. I did that same technique. I'm just going to feather that ML and just look at it, see if I can get some of the sawdust, the dentinal dust into it, and identify that. And kind of in the same perspective, and then I kind of just thought again, I pulled up the CBCT and I thought, you know what? The distal was much more lingually placed towards the tongue than the mesial. So it's not a true horseshoe, right? It was just sort of a lopsided horseshoe. So I knew that I shouldn't go looking as far lingual as I did the distal. So that was my reference point. So I knew where that straight buccal wall was. I just found the DL. And then, man, once I processed that in my brain, I was able to drop right into the ML. And I'm like, just again, I won the lottery. It's a satisfying feeling, actually, when you get to it. So that's really quite nice. Okay, so now I got this problem with gutta percha and sealer kind of going around into these anatomical spaces. So I'm processing that while I'm picking through into the ML and the DL. And the buccal I haven't done too much work with, except for I'm starting to get into that gutta percha. So now I'm going to ask for some irrigant. And I like to pick into the gutta percha a little bit, and then I get this C-form in there, and I'll just agitate it, and I'll get it into it until it kind of bites into that dimple I made in the gutta percha. And I just will put it in there to see how soft it is, and then I'll just check it with, in this case, I went right to a 1506, which is a very flimsy file. And I just wanted to see how packed it was, and it wasn't really packed that tight. And so then it kind of supported my thoughts of maybe this is just a single cone, and I've got sealer kind of in those other spaces, which can be quite difficult to get out because it's sealer, not gutta percha. So I start playing with this a little bit, and I'm also appreciating the fact that the more I pick in that buccal canal, the more I'm actually pushing debris, and probably not clean debris. I'm pushing debris into those spaces, and so I know that I'm going to want to use a GentleWave on this, frankly, for what I just stated. How else am I going to get that out? As I'm doing the effort of removal of dental materials, I'm complicating my own process by virtue of what a file does. Nonetheless, I'm able to identify 3 orphi, and that's good. And so at this point, I wanted to get a length on it, and I am using an apex locator, and I've talked about this in other videos, but for me, just as a refresher, I don't want to do patency pullback. I'm not putting it out and pulling it back in and putting it out and pulling it back in, or reading and letting it stay and going to what's kind of full tone and just kind of dancing around in there until I find like an accurate reading. I'm going down to suggestion. And I do that because I'm having a reference point of my CBCT in the back of my head. And I'm trying to make the two match. And it's a game I play, but measure twice, cut once. And that's what I am. I also know I'm relying upon fluid dynamics to make up that difference. And it's very supported. And the more that I do, the more that I realize that's a good thing. And I'm not, I still believe in patency. I think we'll never really let that totally go as endodontists. But I'm not practicing patency the way that I was taught, or the way that we've kind of developed in a career. I mean, I've been doing this, I graduated in 2005, and I've done that for a number of years. And so it's a little bit of a mind shift, but what I'm seeing the outcomes to be, it's really satisfying to know the delicacies that exist, like we saw that in our micro CTs and other anatomical examples of what true root or true pulp systems look like. And the idea is can we respect that and still address those variations and clean them out differently? and maybe different's good. And so that's kind of what's running through my mind. And back to the concept of dent materials that we choose inside the tooth is I'm going back to a solvent approach, and I'm really doing a lot of agitation. And you can see me just jiggling. I don't have epilepsy. I'm really doing that on purpose because I'm trying to see what the C-form will pull up in that, because I frankly don't want to keep pushing it into isthmus space or that connection in the horseshoe. And not much is coming out, so just that was nice. But it also is telling me there's probably a lot of sealer in those spaces, which is not so nice. All right, so I'm just watching that. I'm going to go and take a file into it and see if I have evidence of orange gutta percha coming back up. Granted, now I know my length. This is a 1506, and I can appreciate that it was previously treated to a size much greater than that. It felt like an 06 just by the visual and tactile feedback that I received. So the previous practitioner used that instrument. I'm also appreciating as I'm going up and down, I'm seeing the fluid move. So I know these guys are connected, at least I think that at this point. But I'm still dancing around to see what comes up and just inching my way, which isn't itching, but moving incrementally deeper or closer to the terminus. Go back to now, I'm actually using alcohol. And the reason is if there is any gutta percha in there, it kind of balls it up, especially when it's been soaking in C-form. And so I did an alcohol rinse here, and looks like I'm going to let that soak, and Lindsay's going to hand me another file here. And I'm in the distal lingual right here. And I'm going to that buccal, and this is where gutta percha would come up. And then pre-bent it a little bit. If you watch what I did, is I just used the pulpal floor to help me pre-bend the file. It's kind of how I do it, as opposed to my fingers. I just use the tooth. And I'm going into the ML right now. And again, I'm inching my way down, and what am I doing? I'm making a pathway for fluid dynamics. That's what I'm doing. Now that I've done that and kind of did some bulk debridement, I'm going with an 04, something a little bit smaller than I was working with. This is a 1504, and I'm getting more passive filing to the apical terminus, and I'm just making sure that I don't have anything stuck along the way. Kind of take a look again here at the pulpal floor. You know, and it makes you think, since this is a bicuspid, and it essentially looks like a molar, it has an actual pulpal floor, not just a bifurcation floor. And, you know, I think guys have asked themselves the question, what happens if you just went right to a molar PI, since it's essentially a small molar? Well, for me, that isn't okay, and it breaks the rules, and I think we all learn to break the rules at times for good reasons. But this isn't something that I was comfortable going to a molar procedural instrument on. So even though it is a molarization, I'm sticking with anterior premolar procedural instrument. That's what I'm doing. So now I'm in prep work, and you saw that I went kind of resituating that butterfly clamp. I added a little bit of Orasil, and you notice there was some curvicular fluid and heme coming into my environment. So I wanted to make sure that I could address that before I get going with my platform buildup, because those things can bite you in the rear end if you don't address that. So I will then, after I kind of situate that, I will then just rinse the whole environment with alcohol. And the idea behind that is I want to make sure I can dry and I can look at a dry environment. And that's what I'm doing right here. I'm just drying it, taking a look, and also wondering if there's still a little bit of caries in there. Just by the way, the chalkiness is inconsistent. So, you know, we're curious creatures. So I'm going to think about that. I'm also not totally content with my isolation. So I'm packing a little bit more in there. And then now, like I said, like it just didn't look like I removed all the dentin. And so again, I'm feathering, I'm not heavy-handed. And I'm just gonna see if I can get any more carious type dentin or affected dentin up. The other thing I know that this actually process helps the sound seal build up. And I'm gonna show you how I'm gonna do that here. So again, I'm just feathering all around, feathering, watching what comes up and finding those pockets of caries. And I wish that they weren't there. I mean, my gosh, this thing has got so much removed already. But I'm really left with no choice, because I don't want a future problem either. All right. I think I'm getting satisfied here. The devil's always in the details, but so are the angels. All right, let's take a look at what we did. Looks a lot cleaner. The color's a little more homogeneous. Got some debris back in there, but I'm going to rely upon the GentleWave. Good before and after in it, but we'll flush up what comes up. This is just with sodium hypochlorite here. It's always our go-to when you think about it, at least for me. Just making sure things are open. I got pathways for fluids. Feeling pretty good. So now, what am I going to do? How am I going to build this up? There's not a lot of walls to push on. I got a lingual sliver, and that's it. So, let's dry this puppy up. See what Lindsay hands me next. All right, so what did she give me? Now this is something that I do. I've talked about it a lot in a lot of videos. This is not alcohol. This is a bendy brush, obviously, but it's conditioning agent. And I use that because it is, well, it's the first part of a bond. And you can go right to a bond as well. You can stick with a conditioning agent. And the decision tree for me is really fear. I mean, if I don't want leaks, and that's what I'm scared of, right? And so if I bond it, I feel like that's an upgrade than just a conditioning, which is also an upgrade from just alcohol drying. And conditioning, a lot of times, especially on crowns or gold crowns or porcelain crowns or Emax crowns or zirconium crowns, I love conditioning those because I get that stickiness with the sound seal. On teeth, when it's not 3/4 of the tooth, I also know that's sufficient. Done that 100 times now. But sometimes with these cases, depending on how it feels and goes on, I'm going to actually bond it. There's a lot of bonding agents. I don't use a single step. I'm showing and demonstrating a 2-step, frankly, because I'm in love with the conditioner. Because I use it as more than one purpose for me, and I like it. That's why I do it. And I feel like it actually cleans any microscopic debris, as it is sort of kind of an acid. And now, once that's done, I can go and apply my sound seal. Now, if you look at this tip, I've modified this tip. This tip isn't just a tip out of the box. This tip is kind of a sickle-looking tip. It was meant for like astringent or hemostatic agent that had a tuft of fibers at the end of the tip, and it was meant to go around the gingiva. Well, I pull that tuft out and I apply it inside. I apply it because it's easy to cake decorate. It's easy to draw my borders with it. And as you can see, that what I'm doing is it kind of slumps on the inside. I find myself to go really slow with this because as it starts to set up, there's a sweet spot. It's like partially set. It's easier to manipulate and move. And you can just draw it up and not really try to touch it. You just kind of let it, the surfaces stick and then just draw it up. And that instrument that I was just using there is a perf paddle. And I love that thing because it just is an amazing instrument. Give it a go. But I use it for dressing the sound seal or pulling it around so I can create a platform. And then I'm going to cure it. Because now what I've done is you can pretend, although it's blue, but it's now pretend that that's your tooth structure. And then you just go to your platform build the way that you've always done it. Got a little careless, put it over the top, but I'll fix it. But I just wanted to put it on there because then it's flat. and I know that it won't rock because my mind is knowing that this is a molarization of a bicuspid, and I really wanted to line up the nozzle of the anterior bicuspid procedural instrument right over the orifice that I can, as best as I can, not leaning to one side or the other or getting off center and maybe it's like on top but it's tilted. I just gonna put it straight up and down. And so I left the nipple of the platform just right over that spot, and then I just tried to fill around it. And sometimes it goes really smoothly, sometimes it doesn't when you do it that way because you can't really see, your hand, one hand's in the way and your assistant's trying to cure it as you go. So I've learned not to stress out about that because actually I can reapply to anything at this point as long as it's not wet. So I don't mind just doing what's necessary. When I got an idea in my mind, I'm going to chase it to the end. And now just anything that I want to fill in, I'll fill in. I also am going to try to make it a little more prominent towards the buccal, a little more bulky, just so if the patient moves or swallows, I'm not tearing off a platform. I mean, after all, the natural dentin is only on the lingual. But that's the reason why I did that little preset. Makes me feel safe, and safe is good. And now I'm going to do my final cure, and then we're going to get ready to rock and roll. Give it the wave. Now, the other thing to consider is, a lot of times people talk about, and I think it's supported in sort of the guidelines on how you do the procedure, that you don't really re-access an APM. But when you appreciate what I just did, how can you not re-access it? Because I'm freehanding building the walls of this thing, right? And I also have done sandwich layers to it. So there's going to be imperfections. And so I can use a high speed, but sometimes that's in throttle back. And I do that a lot too, but I'm more comfortable when there's a crown on it. That way I throttle back and I'm not like gouging the crown walls. But when it's all just sound seal, I just kind of go back to a slow speed. And that's what I'm going to do. And I'm going to look into that and make sure that I can see everything. And again, I do that with the knowledge of using a molar procedural instrument. But even though this is still an APM, I'm still thinking like a molar. So I'm actually going to re-access this so I can see all the orifices. And my hope is that I maximize the fluid dynamics, the lift, the advanced chemistry, the sound waves, everything, and at least give it the best chance to expose that on top of it. Because what else, what do I have to lose? I mean, that's going to be the best bet to clean that aberrancies, to clean the horseshoe out. So that's what I'm doing. And I'm just kind of going to feather this sucker away until I'm satisfied. Now, this is also a good lesson. This is extreme, right? Like, this isn't every day. This is the Stranger Thing case. But if you look really close, look what I discovered. And that's why it's always so good to actually look. I've trained myself to want to look because that's not just fluid on top of those. I've got now sound seal flaked down and fallen on top of it. Is that a problem? Well, let's watch. Is it a problem? Tell you what, the bigger problem was just finding the orifices, but they just flick out. And once they're out, I want them out, so I'm gonna flush them up now. And also, just to ensure that nothing's gonna float up and get caught in my nozzle or block me out of blocking out the exhaust pathway, I mean to say. And I'm just gonna flush this stuff up and make sure that I've got a pathway for fluid. Just trying to focus it here and get a good look at it down those canals. So again, ML on the left, buccal on the right, and the DL kind of in the upper corner. And now I get to go right to the procedural instrument. Now, you've seen other videos, and those who are using it, know that we watch the dancing bubble in the window. And that is right here. I also know I never want to cover that because that's kind of the vent. And this will sputter, which if you watch any of the other videos, that kind of sputtered at me. But I want to make sure that dances the entire time. And that's something that's super, super important to me. And when you think about it, there really is not much difference going on. The look is different. The power, I should just say, the fluid speed that comes through the procedural instrument is difference between the two. But the principles are exactly the same. It's just engineered not with a sound bar coming down as the video, and probably the most of what we do is endodontists, molar endo, so we're used to that. But it's actually doing the same thing. It's just using the sound bar, if you will, is really right here, and it's recreating the same environment. It's just in the head of the procedural instrument. But we get the same sound flow. We get the same circulation power behind it. The principles are exactly the same. I mean, the console is still optimizing the fluids by degassing them. It's still exhausting through the sides of the procedural instrument. But just imagine that this little sound bar is kind of right here at the top of that procedural instrument. But we get the same cavitation cloud that forms right there, which is essentially what the dancing bubble is. And then that's what releases the energy, just like they're talking about, like nothing's different. That sort of transfer of the sound through the fluid is the same. And like I said, because this is a molarization, that's happening high. And so that was one of the other reasons why I built the platform the way I did, because I actually wanted to lower that as low as I could, which to me, the determining factor was that little lingual shelf on that tooth, and then build up that wall. And then I wanted to keep it as centered of the three that I could. And so I was trying to target that. And that's why when I opened up the window of the sound seal, I was making sure, because I want to employ this technology right on top of that, because this is one of the outliers. Strange, but it is an outlier, right? So that's why that was my thought process going through it. And to me, that's the best that I could do for my patient. That's what matters most to me. And my hope is that the energy, the whole trifecta of what this is, gets into those spaces that I can't get into. And if at best, get in and around sealer, if sealer's been kind of set in there from the previous treatment, and maybe it finds its way through it, and dissolve anything organic, remove any of the smear or biofilm that may be there through the EDTA. And that's what I want for my patient. And this patient's been through a lot. Like, this patient was not like a newbie to dentists and has been around the block. He literally has been around the world seeking out dentists because he's had problems with his teeth. And he's had a job that's, he's lived in different countries. He's actually, I don't know if he's a citizen or not, but he was born in another country. And he's living, close to my office and came in to see me. And those were some of his concerns. He was very much, his mindset was, this has got to be different. And he had no idea that really his tooth was different. But he was smart enough to know that he needed a different kind of root canal because the first one didn't work. And he was a guy that was clever. He went out and searched high and low and did his homework and tried to figure out, even for himself, what would be the best kind of experience and what would be the best outcome for him. And so we talked about that, and that was kind of an interesting experience from the patient perspective. And so I was eager and I was excited to attempt this challenge of this molarization of a premolar. So I'm running, and we're going to go through the whole protocol. If you have a console, you'll know the numbers by now. But it goes through a degassing process, and then you go through your bleach cycle that's going to be normalized at 3% for 5 minutes. You're going to go through another rinse, and then you're going to go through a normalized EDTA roughly around 8% for another 2 minutes. And then a final rinse of water. And then for me, once that's done, I'm going to go rinse it again with some hypertonic saline if it applies, but I end up doing it every time. When I mean if it applies, it really depends on what the experience is after the procedural instrument, meaning what is coming back up through the microanatomy and the main anatomy of the root pulp system. So watching the dancing bubble. Sometimes, as you'll see, the fissures will come, and that might be your position, might be something coming up out of the canal, and sometimes I'll give it a little jiggle, especially in a retreatment, if I have a thought of gutta percha or something coming up. But you also have to be mindful if you see a little fissure, meaning it looks like a little stream that just shot through there for a millisecond. I don't know if you paid attention and you saw that, but that could be your sound seal breaking down, and that's why I put all that effort into it up front, because I don't want that to happen. And I want to employ the entire time protocol to the best outcome that I can give this tooth. And so you got to be careful with that and really be quick-witted on the knowledge of what the procedural instrument is telling you. If it's a leak, if it's a patency problem, meaning it worked its way out, maybe you over-instrumented, maybe it's, like flushed out, washed out, caries, and now it's found a little portal back to the gums. Those are the things as you get more advanced with the GentleWave that you need to take into consideration. But if you can quickly reestablish the dancing bubble, those thoughts kind of just sort of attenuate in your mind, and then you're really comfortable again, like, okay, I'm good, I don't have to chase anything. And so, you know what? That's my friend, and it will always be my friend, and I'm going to leave it my friend, hopefully for the entire cycle. If you notice, it's gotten dark outside. We're getting cold in Utah. It's getting cold. It's been good though. We've had a lot of fires. Both sides of my house, where I live in the mountains, both sides have lit up this year. It's been sad. But now it's been wet. Now I got to worry about mudslides. Just about done here. You always can tell if I'm getting close to being done. You can't see the console, it's right here, and the window's right here, but just watch my assistant. Then you're gonna know what's going on. So again, you saw these little snafus. I'm towards the end of the cycle. So again, I'm gonna go through the decision tree, caries leakage, sound seal breaking down, over instrumentation, whatever you want to go through your decision tree. But when it quickly kind of reorients itself and you get that dancing bubble back, a lot of times it's just the position of the procedural instrument on the platform, and it's just a little hand jiggle. You find your center again, and then you go. You just got to get grounded. I don't know if I was talking to my assistant right then or if I looked away or had an itch, but it was probably my hand that moved. Now if you notice, my assistant has not been suctioning along the way. I mean, it's a pretty solid platform. Sometimes when I take these things off, and especially when you have that, a lot of times I like looking at the underside of them. And something that I do is I'm always trying to be taught the tactile, the haptic feedback of the experience along the way. I feel responsible for that, and I always feel the more information I give myself, the better decisions I make along the way, and look for the feedback. So I could look for pitting out, I could look for flashing, vibration. If a little sliver of sound seal came off a wall and it vibrated, that could give you a flutter. Those sorts of things, and that could also explain why repositioning kind of found center again. And you start learning to kind of ask questions differently and answer them the more you do of these things. But nonetheless, I feel clean. I feel really clean inside there. So we take a look, and my horseshoe really looks like a tripod, but that's what it is. So maybe there's interconnectivity down a little lower. Now, I'm not going to take a burr and trough that out. I'm hoping that as the fluid goes down, it comes back up and creates a racetrack internally in those anatomies, and creates a racetrack or a system of fluids coming in, down, and around. And maybe that's what's happening below that pulpal floor, because I do believe they're open. And after all, I saw sealer from the previous treatment into those spaces. The only way I can answer those questions now is going to be upon obturation, which is still part of the protocol. And so let's watch. And what I want to watch for is what the sealer is going to do as I apply it. So first thing I'm going to do though is I know my lengths, and I'm just using a 20 cone, and I'm just actually putting them in the canals, and I'm just sort of saying, hey, am I down to the end? And because I haven't done a working length, I mean, I've done measurements, but I still like to do working length type x-rays. Now this is a cone fit type x-ray, to be more technical. But I'm selecting my cones. I got two 15s and a 20 going on in here. And let's take an x-ray. So there you go. Kind of interesting. I see remnant sealer. I see kind of the horseshoe in tripod form. So it'll be interesting to see when I put sealer in there what to do. Now a lot of guys, there are guys that will dry, put sealer in, put the cone in, and then sort of do a sealer cone fit. And I think that's great. Jimbo Smith does that, and it's fantastic. For me, a lot of times I'm doing this because I'm going out of the room, doing another patient, coming back in, and if there was any activity, apical activity coming back into that canal system, that's the time I want to sort of let things breathe and settle down a bit, just simmer, and my life gets simple, and I'm not picking at it along the way because I'm an endodontist and I'm dealing with another patient, so my mind's distracted. So that's good. Then I'll come back and look at my environment, and now I'm going to try to make it as dry as possible. So just did a little microsection, and Lindsay's going to hand me some paper points. Again, that's my DL. That is my what I call buckle. And last but not least is my ML. All right. And I don't know why I always obturate lingual before buckle, but that's what I do. In this case, I started with the DL. And I'm going to do an inject, and then I'm going to look into the buckle and the ML while I'm placing my cone to see if any sealer comes up, which it did not. At least that I could see. And just do a little searing off, a little down pack. Back to a paper point, wick out whatever may be, if there was a communication there. My idea is I want to wick it out if possible, any moisture, sealer, whatever. Now I'm going to do another injection. Again, now I can look in the ML, so get that little gutta percha out of my mirror. And place my cone. Line it up, don't bend it, okay. Kind of pulled over the top of the ML, but let's take a look as I do a little down pack. And I can absolutely see a little bit of sealer right there flow up the other side. Now you could argue, did it come down from the top or the bottom? But if I put my little paper point in, it crinkled. Kind of high. Time to make a decision. You can think about this a couple different ways. Maybe I pushed gutta percha in and I didn't get to the end, and maybe I'm blocking myself out. And so if I put a cone and do what I'm doing, maybe I put myself short. Maybe it flowed around to the terminus and life is good. But either way, I do know something came from the buckle to the ML in that experience, and I'm not to my quote-unquote length that I was on my cone fit. Kind of interesting little debate to have in your head. And you've got to feel comfortable with your technique and your protocols to know how to best solve that. It's not an irreversible event because you can always come back and address it. But what I wanted to do was an experiment on purpose. And if you watched what I did, I just put the sealer back in. I didn't use anything else. And then I injected, a cone, even though I tried the cone in, and then I injected in the buckle. And I watched gutta percha come up the ML. And then all I did is down pack. So even though Lindsay's there on standby trying to hand me another cone, I said thanks, but no thanks. But I'm giving it a good push there because I want to make sure it flows in on both sides, because again, I still have to answer my own questions. And of course, I'm going to take an x-ray to prove it. Now, if you watched again, I went back to the buccal to see if anything else came up, which it didn't. And so now I'm going to kind of just fill in the coronal space here. Kind of give it a final push. Make sure I can fill up the three-dimensional space in that isthmus, because I do feel like the horseshoe's connected here at some degree, somewhere along the canal. So let's take a look at it, and this is just a warm thermoplasticized gutta percha backfill. Finally wiped my mirror. That little sealer spot on my mirror is driving me nuts watching this. Good. Clean, clean, clean. So I got some sealer in that access, a little bit of gutta percha flashing, so let's clean that out. All right, so now what we're doing is just taking an alcohol, this is just alcohol on a bendy brush, and I'm just cleaning up any schmutz that's left and give it a dry. So now that I'm essentially done, we got to address restoration temporization. And kind of as the decision tree as dictated by my referring office, in this for instance, the request was made to do a temporary. And the good news is, and I got a little curious at what that little discoloration was right there, so I just wanted to fill it. That's all that's going on there. But there's the floor. You can see it's nice and dry. Putting in a little sponge, and like I was just saying, this is a temporary state. So the good news is the patient's really motivated to do good dental care, and it's going to go right back in. And I'm just going to pack in a temp. You know, sometimes when you do this, and we've all experienced this, because I do single tooth isolation, split dam people perhaps have a leg up on me in doing a different technique when you have these kind of class 2 walls, because as you jiggle this loose, you know, this on both sides potentially can dislodge that. And that would be one of the reasons, the rationales for doing maybe a different technique. I tend to always do it this way, and I've kind of stuck to my guns on it, for better or for worse, and so I'll have to address that at times where it does dislodge. This one did not, which is, thank goodness. And do a little bite check, and then after this, it's just a little bit of cleanup around the margins from the OraSeal, kind of tighten up, dragging it across, and tighten up the temporary filling to make sure those margins are closed. And then it's just off to the dentist at the next available appointment between my patient and the referring doctor. Again, you know what I'm using there is not an Explorer. That's actually that Perf Battle again. I really like it. So I actually have one on every tray now. So there you go. There's the before and the after of the case. You can see sealer shooting down that round robin. We can see connections in that buccal and the ML. Grand isthmus right here. And sure enough, just sort of, you know, a trident down here, but a single distal lingual canal. And so that's my three-dimensional anatomy. And again, there's the starting point. And it's very interesting to look at the little details and study that to the best of our ability of what was there previously and what is found postoperatively. I think I actually just misspoke to you. I think this was actually probably some sealer injection out a lateral canal from the very beginning, from the previous treatment. I really appreciate you guys supporting me and watching this stuff. I hope it's fun for you. Always comment. We'll get back to you as soon as we can with any questions or comments. Don't forget to subscribe, after all. And see you till the next time.